Good afternoon, dear colleagues. It is a pleasure for me to participate today with my colleague, Dr. Raquel Lopez, in this Neurology Video Journal Club, where we will be discussing an important topic on the comorbid mood and anxiety disorders in women with epilepsy during their pregnancy and postpartum period. This is based on a study that was published in Neurology by Dr. Kim Mueller and his colleague from the Monit study. This is a very important study that I think brings a lot of important pearls for the clinical management of any woman with epilepsy during the course of her pregnancy. Joining me in the discussion is Dr. Raquel Lopez. Dr. Raquel Lopez is a professor of clinical neurology at the University of Miami, Miller School of Medicine. She is the director of the Southeastern VA Center of Excellence, and for many years was the VA Center of Excellence at the Miami VA. And one of the unique features of Dr. Lopez is that while she is a neurologist that has devoted a lot of time in the training of management of psychiatric comorbidities in people with epilepsy. And she's probably one of the few neurologists in the world that has learned and does cognitive behavior therapy for patients with neurologic disorders, including functional neurologic disorders. So her interest in psychiatric comorbidities makes it an ideal partner in the discussion of this topic. And it's I feel very honored to share this podcast with her. I am a professor of clinical neurology at the University of Miami, Miller School of Medicine, and the director of the Epilepsy Center here. So without further ado, Raquel is going to describe the findings of this very important study. Raquel, do you want to go ahead?
Yeah, first of all, thank you very much for the invitation from the Academy to have this opportunity to discuss this interesting paper. First of all, Dr. Kanner, I'm not a professor yet. I am an associate professor. Thank you for the promotion. Second of all, Dr. Kanner has been my mentor for about 10 years. And I think he's the well-known leader expert in psychiatric comorbidities in patients with epilepsy. And has been kind of like the pioneer of understanding the bidirectional connection between epilepsy and psychiatric disorders. This topic is very close to me because interestingly enough, I'm an epileptologist, but I was one of a patient who developed epilepsy during the pregnancy for the first time. So I became very open about my journey, and I don't think this is a coincidence for me now getting to know more about this condition, especially in pregnancy when this happened to me for the first time, and having some symptoms during the postpartum as well. This is a very unique paper from Dr. Mueller. So first of all, I'm just going to go about the principal findings. Here at the table, you can see that the cohort is pretty large. So it's divided among women with epilepsy compared to control women without epilepsy. So the total number of pregnant women with epilepsy was 331. And pregnant women without epilepsy, 102. The non-pregnant women with epilepsy was similar, 102. So the findings as follow is that the paper found that depression symptoms are definitely worse during pregnancy in women who are pregnant with epilepsy and women who are non-pregnant with epilepsy. So the common variable here is just having epilepsy. The second finding is that the depressive symptoms tend to get worse or being exacerbated during the postpartum in all the groups. So especially in pregnant women with epilepsy. So once again, having epilepsy and being pregnant seems to have a significant impact, increasing the chances of developing depressive symptoms. The third finding, anxiety symptoms were also worse during the pregnancy in pregnant women with epilepsy. Now, it's interesting to see what were the factors associated with these major depressive episodes. So the most important factors that can predict symptomatic depression are number one, severe epilepsy. Number two, having been exposed to polytherapy. Number three, unplanned pregnancy, which is fairly common, more than 50% of the pregnancies, especially in women with epilepsy, could be up 70%, and a lifetime history of a mood disorder. Interestingly enough, the last finding is that suicidal ideation was associated with symptoms of anxiety mainly.
So we have in this study a variety of concepts that are extremely important for clinicians to take into consideration when they're managing any woman with epilepsy. Number one is that depression and anxiety disorders are more prevalent in people with epilepsy than in the general population. And in fact, 1 out of every 2 people, 1 out of every 3 to 4 people with epilepsy in the course of their life will experience a mood and or an anxiety disorder. And this is in the general population. This is a common occurrence. In women with epilepsy, this presentation may have a pleomorphic presentation that is important to recognize, as some of these patients may present with major depressive episodes, while others may have a subsyndromal expression of the symptoms of depression and or anxiety, and Raquel will give additional details about this clinical presentation. But the recognition of these different manifestations is of the essence, as it can often go unrecognized if we just are following the diagnostic and statistical manual diagnostic criteria in trying to identify women with mood and or anxiety disorders. And another important pearl for every clinician is you cannot go without doing a comprehensive evaluation of any patient with epilepsy without screening for mood and anxiety disorders, as this has important implications in many areas of the management of the patients, as well as in the prediction of the recurrence of these conditions in the course of their epilepsy, and as we will see in the course of the pregnancy. We will discuss on the association between the severity of epilepsy and the occurrence of symptoms of depression in pregnant women with epilepsy with respect to common pathogenic mechanism that exists between these conditions. And finally, we'll have a brief discussion on the treatment of depression in pregnant women with epilepsy. So Raquel, do you want to highlight the importance of recognizing these 2 comorbid conditions?
Yeah, absolutely. So I think in our experience and in practice, I think we both want to emphasize the importance of the appropriate screening of the psychiatric comorbidities. So a couple of things. We do understand how busy neurologists are in the practice, and we have only allocated time to cover multiple things that are happening, but I think appropriate screening can come or starts even from the waiting room, where you can just perhaps have validated questionnaires filled out by the patient when they are waiting to be seen. What is the importance of that? The importance of that is, as this paper found, there are pleomorphic presentations that is not the classic DSM-5 criteria of major depression disorder that is being found by the DSM-5 with the classic presentation of maybe 3 findings over the past 2 weeks. When we use the appropriate questionnaires, either the NDDIE or the GAD-7, we can find people that are symptomatic of these comorbidities and are not even aware of them having symptoms of either depression or anxiety because they think that is normal. Now, in terms of subsyndromic depression, what does that mean by that? It means that the diagnosis of symptoms of depression can be found with symptoms different to the common symptoms of depression, which could be sadness or even anhedonia. Okay, subsyndromic depression can present with other symptoms such as the most common one is insomnia, up to 45% of the patients, chronic fatigue, recurring thoughts of death, weight gain, slow thinking, or hypersomnia. So once you start interrogating for more specific questions instead of an open question of how are you feeling, you can be able to recognize those patients and start an early intervention.
I wanted to add one thing, Raquel, to those important concepts that you raised, and that is that when we're talking about depression, we also have to be thinking about symptoms of anxiety because the two conditions often occur together, as seen in the data presented by Miodor's group. Failure to recognize the symptoms of anxiety in somebody who has depression and failure to target those symptoms in the management can result in persistence or recurrence of the symptoms of depression if you are just targeting those symptoms for the management of these patients. So that's a first point that I'd like to highlight. The second point is that when we're talking about depression as a frequent comorbid condition, we have often thought that depression is the most frequent comorbid psychiatric condition in epilepsy, but in fact, anxiety is the other condition that is as frequent as depression in people with epilepsy. And this is, I think, an under-recognized point among general neurologists and clinicians and sometimes even psychiatrists.
Yeah. And the other thing that we have to be mindful is that recognizing these psychiatric comorbidities that are present are not only going to intervene on decreasing the symptomatology or recurrence of the disease, but also improvement of epilepsy itself, and also improvement of quality of life in the patient. And also you will be able to determine the severity of the symptomatology of the psychiatric comorbidity, knowing that if this patient perhaps is going to be pregnant or have postpartum depression, who is going to be at higher risk of being symptomatic as it was demonstrated in the paper.
So the screening instruments that clinician can use, as Raquel was saying, can include the generalized anxiety disorder 7, which is a 7-item self-rating instrument. And if you score above 10, you are likely to be suffering from a generalized anxiety disorder and also a panic disorder. It's, as Raquel said, an instrument that it takes 3 minutes for patients to include. With respect to screening for depression disorder, the neurologic depressive disorder in epilepsy, the NDDIE, we use it for the screening of major depressive episodes. If you want to screen for symptoms of depression, the Beck Depression Inventory is an alternative. The NDDIE is very short, only 6 items. If you score above 15, you're likely to be suffering from a major depressive episode. The Beck Depression Inventory is a little longer, it's 21 items, and it breaks down the severity of symptoms of depression into mild, moderate, and severe. But these are instruments that we encourage our colleagues in their neurology practice to use for detecting those patients that are symptomatic. The next important point that this study shows is that patients may not necessarily meet criteria for a major depressive episode, but they may be symptomatic with symptoms of depression and or anxiety. You don't need to meet major depressive episode criteria to deserve treatment. And in fact, studies have shown that the impact of subsyndromic forms of depression and or anxiety have a significant impact on the quality of life of people with epilepsy compared to control. And sometimes the magnitude of the impact on the quality of life in people with subsyndromic depression is can be as significant as that of a patient with a major depressive episode or a generalized anxiety disorder. So it is of the essence that we look for these symptoms of depression and or anxiety. Raquel, do you have any other observations with respect to these points?
Yeah, so I think that the point of the pleomorphic presentation is important also to consider that the intervention varies, because if these patients don't have a diagnosis of a severe major depression disorder that requires the initial use of psychotropic, especially antidepressants, those patients could be treated with early interventions of psychological interventions that are non-medical interventions that can favor the treatment as an initial intervention. The psychological non-medical treatment are very easy to access. If you don't have a department of psychology working in your institution or in your practice, you can educate these patients with different tools that are now present online, with different apps where you can refer them for different techniques as CBT or mindfulness, or also breathing exercise, psychoeducation, where you are kind of like educating the patient about what is to have a mental illness, education about avoiding the stigma, educating the family to be part of the treatment of the patient, helping the patient about the tools not only, but also how to reach for help. So as Andy mentioned, the quality of life could be affected significantly in both spectrums: patients who have mild depression, patients who have severe, patients who have pleomorphic in the middle. And the quality of life is not only affecting the woman who might be getting pregnant or is pregnant or will deliver a baby, but also the baby itself, because the studies have shown that these babies are going to have also an effect in their quality of life, their cognitive development, and the psychological development. So the impact will continue progressing to patient, baby, and eventually the community.
So Raquel raises the important concept of treating patients with women with symptoms of depression or anxiety or major depressive episodes or generalized anxiety disorders with psychological strategies, which often in pregnant women may be an attractive option because women may be concerned about the use of psychotropic medications during their pregnancy. Also, there is this long-standing misconception that the use of antidepressants can lower the seizure threshold. I'd like to take this opportunity to clarify again that the use of antidepressant medications in patients with epilepsy in general, particularly the antidepressants of the serotonin, selective serotonin reuptake inhibitors, the SSRIs, and serotonin norepinephrine reuptake inhibitors, the SNRIs, have been found to be very safe in people with epilepsy when used at the therapeutic doses. The risk of seizures associated with antidepressant medications essentially has been identified in patients who've taken overdoses, but when used at therapeutic doses, they are very safe. Now, are these drugs safe in pregnant women with epilepsy, and should they be considered? And the answer is yes, they are safe. There are population-based studies that have been done in the Scandinavian countries as well as in Australia that have shown that the risk of teratogenic effects in pregnant women who were exposed to an SNRI or an SSRI were not any different than those women that were not exposed to these psychotropic drugs. And a larger study done published in the New England Journal of Medicine in 2007 suggests that any risk is very mild compared to the failure to treat these conditions, particularly when the depressive and anxiety disorders require pharmacologic intervention for the reasons that Raquel mentioned very clearly. The impact on the ability of these women to take care of their baby during the postpartum period that can be significantly interfere if not treated. But one of the pearls I want people to take home is if you need to use or recommend an SSRI or an SNRI during pregnancy or in the postpartum period, you can do it, and the risks of teratogenicity have not been panned out by the available data.
And also in that paper that you mentioned, Andy, with like 54,000 patients in the cohort in the Oslo study that was published in 2023, also demonstrated that the stopping the use of antidepressants of women who suffer from major depression disorder demonstrated the highly rate of relapse on depression, not only during the pregnancy, but also postpartum. So the moment that you stop current treatment, you are raising the possibility of complications, number one, trying to avoid teratogenesis, which is not existent. And the second thing is in the ones that are new, having a new onset of symptomatic major depression, will also have probably a deterioration of their mood condition during the pregnancy and most likely during the postpartum.
Now, one very interesting observation by Kim Muetter's group was the association between the occurrence of symptoms of depression during pregnancy and the severity of the epilepsy manifested by a higher number of anti-seizure medications used, by more than one seizure in 90 days. And the other important variable was the history of a mood disorder, a lifetime history of mood disorder. So does that mean that the symptoms of depression are a consequence of the increased frequency of seizures? Or could the increased frequency of seizures and the increased prevalence of symptoms of depression and anxiety may be the result of common pathogenic mechanisms that are present in both depression and anxiety and epilepsy? It's, I think, intuitive to think, well, if you're having more seizures, you're more likely to become depressed or to become anxious. Yet we know from a large body of literature in people with epilepsy that people who develop a psychiatric disorder, including depression or anxiety, before the onset of the epilepsy, have an increased risk of developing a treatment-resistant epilepsy. And the explanation for that increased risk of treatment-resistant epilepsy also is coupled with the observation that if people with depression and anxiety disorders and suicidality compared to controlled have an increased risk of developing epilepsy. This is what we know as the bidirectional relationship between psychiatric disorders and epilepsy that was described by Dale Hesdorfer and other colleagues. So in my personal opinion, I think that what we're seeing here with this association between severity of epilepsy and the occurrence of depression is an expression of common pathogenic mechanism between these two conditions. And what I would postulate is that one of the common pathogenic mechanisms is the hyperactive pituitary adrenal axis, which result in an increased secretion of cortisol. This is a phenomena that occurs in patients with primary major depressive episodes. It occurs in patients with anxiety disorders. It's been well documented in animal models of epilepsy as well as in patients with temporal lobe epilepsy. And women during pregnancy have an increased secretion of cortisol that reflects a hyperactive pituitary adrenal axis. So you've got a situation where a woman during pregnancy has an increased secretion of cortisol. High levels of cortisol can result in an increased glutamatergic presence in the synaptic cleft, which can then increase the hyperexcitability of the epileptic circuit, which can then result in increased frequency of seizures. And if the patient has a severe depression, that may be another factor that can enhance that physiopathologic mechanism. So I personally am of the opinion that this phenomena that we're seeing is an expression of that bidirectional relationship between these psychiatric comorbidities and epilepsies. What is your thought, Raquel?
Yeah, the way I just see it, and for me it's easy to understand what you just mentioned. I think that has been your world research and the major pioneer in this bidirectional evidence of the duality of depression and epilepsy, as well as, of course, anxiety and epilepsy, but more importantly, depression. That I see that pregnancy by itself plays a role of significant stressor for women with epilepsy. So if you think about that being an stressor, you can think that that woman is kind of getting a double hit. The one who already had a psychiatric comorbidity with depression, who has an underlying higher level perhaps of cortisol, being exposed to an increased load of that cortisol running in the system, which is going to decrease the threshold of having the activated excitatory potentiality of having more epileptic seizures. And in addition to that, once the baby is delivered, you are adding more stressors because you are adding being the provider of being a parent, and also the sleep deprivation. So you're adding on more triggers that make the epilepsy more difficult to control. And if the epilepsy gets more difficult to control and you're sleeping less, you're going to get more symptomatic of the underlying depression. So the loop continue being activated and escalated as a snowball. So as we were initially trained in medical school, the teaching point back in the old days is like women cannot get pregnant because the babies can have epilepsy. Now I think the awakening for the new trainees is that women, of course, they can get pregnant. The likelihood of having an abnormal child is very, very low, or it's similar as having a non-epilepsy. But the teaching point right now is that take care of women to make sure you are taking care of the women as a whole, with the psychological component and also the vulnerability of pregnancy developing symptomatic depression and anxiety, and act on it. Don't wait until things get out of hand, or just simply refer to a psychiatrist, which in the real world is going to take probably 3 to 4 months, or maybe won't even pay by the insurance. It's going to be out of pocket. So you have to be the first gate of mental health treatment for those women who are pregnant.
So there you're raising a very important concept, which I am a strong advocate for, and that is that, in fact, neurologists should be trained on the use of these type of psychotropic drugs when managing patients with epilepsy, or for that matter, when managing any neurologic comorbidity, any neurologic disorder associated with a psychiatric comorbidity. The use of these psychotropic drugs, in fact, is easy. It's not that complicated. You need to know that the doses, the target doses, are the same that you would use in any patient who is not depressed. Any patient who is not epileptic. And in my personal experience, treating depression and anxiety disorders in pregnant in non-pregnant women with epilepsy is even easier than treating them in patients with primary mood and anxiety disorders. So people with epilepsy respond to lower doses of these medications with full remission. So I think that we have covered the most important concepts of this topic, and we're coming to our time allotted for this discussion. Raquel, do you have any closing thoughts that you want to share with our colleagues?
I think we pretty much covered everything. I will emphasize our responsibility for teaching the new generation because the curriculum has some gaps. So I think we can intervene with the education and empower the young people to be able to help with this public health crisis that we have with mental health. And then lastly, the referral to the psychiatrist also will be for patients who are definitely not improving with the first agent, or are perhaps having a psychiatric emergency where they do have the need of more expertise in the care. Thank you for the opportunity.
Okay, so thank you so much for accompanying us into this Neurology Journal Club, and we hope that you have benefited from this discussion, and we appreciate your attention.